Hi, everybody. We're just going to wait another minute or two for everybody to join. I think we can go ahead and get started. So welcome, everybody, to the Johns Hopkins University Virtual GIS Week. Okay, we are currently in the middle day, Wednesday, of our 3-day event session. We've had a great sessions yesterday, and we have 2 sessions for you today, including kicking off our keynote address from Dr. Geraghty. And then later this afternoon, at 3 p.m., we have our lightning talks. So we're so glad and excited that you can join us today. My name is Frank Curriero. I am a professor at Johns Hopkins Bloomberg School of Public Health, and I direct the Johns Hopkins Spatial Science for Public Health Center. Helping me moderate today is our Associate Director for the Center, Tim Shields.
Howdy, everybody.
I will do the introduction and get us started, and Tim will follow up after our keynote address and do the Q&A. And you can post your questions throughout the talk in the Q&A box, and we encourage you to do that, as we can answer some as we go through, but we'd like to leave some of those for later on that we can pick and choose from for the keynote address. So let me introduce some of our sponsors for GIS Week. Okay, so GIS Week is sponsored by the Johns Hopkins Center for Livable Future. This is an academic research center focused on the intersection of public health, the environment, and the food system. And also co-sponsored by the Johns Hopkins Spatial Science for Public Health Center, which is also an academic research center focused on the development and application of spatial analytics, GIS, and spatial statistics for public health research. Just a few housekeeping notes. Okay, the webinar is all going to be recorded, as all our events this week are recorded, and they will be posted on the registration page afterwards. And also, like I said before, please post all your questions to the Q&A box, and we'll have time at the end of the session to answer those questions. And as you go through the session, please type your questions in that box. You don't have to wait till the very end to do that. So it is my honor and actually extreme pleasure to introduce Dr. Este Geraghty for our keynote address today. Dr. Geraghty is the Chief Medical Officer at Esri, developer of the world's most powerful mapping and analytics platform. I'm sure everybody's familiar with the Esri products. She leads business development in health and human services and is passionate about delivering value through a geographic approach. You'll see a lot of that in her talk today. Formerly a deputy director with the California Department of Public Health, she led the state's open data initiative there. She also served as associate professor at the University of California, Davis, conducting research on geographic approaches to health policy and community development. In addition to degrees in medicine, medical informatics, and public health, Dr. Geraghty is also a geographic information systems professional. If you want to know a lot more about her work, just sit back and relax, because she's going to give a very exciting keynote address on the use of geographic information systems and the breadth and depth that all can entail. And if you want to know more after today, please just use your Google. She has a very impressive Google search profile. So you can find a lot about her on there. Dr. Geraghty, I'm going to stop sharing my screen now, and I will let you share your screen, and you're welcome to get started whenever you're ready.
Thanks so much, Frank. I really appreciate it. And thanks to you and Tim for the invitation today. And happy GIS Day, everyone. It really is my honor to have this opportunity to celebrate this day that's meant to build awareness about the various uses of GIS in organizations around the world. Now, this year, GIS has been front and center in health and the fight against the SARS-CoV-2 virus, which has commanded so much of our global attention. And you'll hear about GIS for COVID-19 from other speakers. So while I'll mention some of the applications, I do want to take a much needed break from the pandemic and talk about what else. What else can you do to support better health using GIS? Well, let's start where we always seem to start, with data. We have nowadays a truly 21st century dilemma that starts with the notion that getting data has never been easier. You no longer have to rely solely on the data that you have individually been able to curate and collect. There are literally hundreds of thousands and perhaps millions of geo-enabled health data sets that you can access at any time. And this slide is simply showing you a sampling of the data that we at Esri make available. However, despite our improved access to data resources, understanding data has actually never been more challenging. Here are some statistics on that. Do you realize that 80% of an analyst's time is spent searching and processing data rather than analyzing it? Similarly, 60% of a data scientist's time is spent curating data rather than producing accurate models. When it comes to decision making, we know that less than 50% of structured data is actually used in making decisions, and worse, less than 1% of unstructured data like reports and emails and documents that we use every day are ever used in the decision-making process at all. It is truly a 21st century dilemma, but there is one answer. Map it. And of course, I mean that very literally. So that's what thousands of people have done for COVID-19. The GIS community has built dashboards, hubs, maps, and apps to help understand where the virus is spread and, of course, what we should do next. It's really been so inspiring for me to see all of the effort that's gone into the geographic visualization of COVID-19. When you put your data on a map, things actually start to happen. Patterns become clearer and relationships are a little bit more obvious. And with geography providing that contextual information, we can make greater sense of all those bits of data and create new insights and see, ultimately, the forest for the trees and get answers to our most important questions. And of course, this is called location intelligence, and it can really help you to see what others can't. So let me give you a simple example that came from one of our Esri business partners, a company called Data Story, and I thought it was really a clever way for them to prove a point. So you've all seen these machines on the slide, right? These are called phoropters, and ophthalmologists and optometrists use them to help find your ideal prescription, to help you to see 20/20. Now in the process, they will test your vision and they will ask, what's clearer, number 1 or number 2, for example. So I'm going to try this out on you. This is a fake list of patients for a healthcare system. We see these kinds of lists all the time, right? So if you want to understand the patient population being served by this healthcare system, which is clearer, this view or this view, where you can see the patient population in context with all of the clinic sites in the region. Still, that is a lot of dots on a map. So let me adjust your vision one more time and ask you if this is clearer or is this one better? With the heat map here, we can get a much better idea of the density and geographic spread of the patient population around the various clinics in the system. So I think you get the idea. Using geography to improve clarity is a natural for many different kinds of questions. Now imagine what this year might look like without mapping and GIS. Case and death data for COVID-19 might have been collected in spreadsheets or stored in PDF documents. Even the early JHU dashboard data was originally collected in Google Sheets. Well, certainly there would have been and continue to be additions of visualized data with graphics. There's no question that those can add a lot of value and make greater sense of the data and improve our vision and the ways that we connect those dots to develop deeper understanding. But I think it just doesn't hold a candle to the way that geographic information puts data into context. It shows us how places compare, what the trends are in the short term and in the long term. Geographic data really provides, I think, something special that helps us to understand patterns and relationships and use that information to more intelligently respond to whatever health challenge we're facing. Now, I know you're going to hear more about this dashboard later on, and I can only imagine that it's been a great source of pride for JHU. From my personal view, this dashboard has changed the world in a number of ways. I loved that Johns Hopkins University, the team putting this together, put data sharing first. This enabled the entire world to take advantage of the data for their own needs. The dashboard shared the value of GIS for health in a really big way, and it literally showed people how they could see the developing crisis more clearly. It also built an expectation for real-time and near real-time data. And I think that the dashboard and the JHU team exposed some gaps in our data sharing policies and our methods and interoperability gaps that will hopefully lead to improvements going forward. It was definitely the right tool shared at the right time, and I just wanted to take a moment to congratulate the JHU team for all of their efforts on this. So we are talking about seeing clearly, and I want to step back for a moment. In health, for many years, in my opinion, we've likened seeing clearly with a microscopic point of view. But today I'm going to focus on a telescopic perspective, a broader view, and in fact, probably a more holistic story of who we really are. You know, when it comes to our health, it's been shown that where we live, when we exclude genetics, 80% of our health outcomes are driven by that context of our life places. So it's our physical environment, it's our socioeconomic conditions, and those influence our personal behaviors that really lead to our health outcomes. And some might share a preference as if it's a choice about whether the microscopic perspective or the telescopic perspective is the right one. And I'd say that rather than determining the better perspective, like is your zip code more important than your genetic code, that we should put our energy into figuring out how to bring these diverse ideas together. And actually, I think that's been happening, and I want to spend a few minutes sharing why I think that's so. So some of the evolutions in medicine and public health that I've seen are what I'm going to talk about. It's the microscopic and the telescopic, and they're converging in really useful ways. So I want to begin with the concept of personalized medicine. And this was a trend that became very popular during my training years. And the idea is that diagnoses and therapeutics were to be much more individualized for each and every person. And the focus here was on all of the omics, genomics, proteomics, metabolomics, and the like, all very important scientific work. But then the idea progressed a little bit from into an interesting concept with the notion of precision medicine. Now, Francis Collins defined precision medicine as an emerging approach for disease prevention and treatment that takes into account, it takes into account people's individual variations in gene and environment and lifestyle. So we have a microscopic and a telescopic person-based perspective, and I actually think that's pretty great. So here's one of the next things that happened. Community health needs assessments, we call them CHNAs. They became required for tax-exempt hospitals as a result of the Patient Protection and Affordable Care Act. And these assessments and strategies create an important opportunity to improve the health of communities. What they do is they ensure that hospitals have the information that they need to provide community benefits that meet the needs of the local population. By statute, the CHNAs have to take into account input from persons who represent the broad interests of the community served by the hospital facility, including those with special knowledge or expertise in public health. So that's kind of interesting, right? Healthcare and public health are coming together. We also saw this play out in the way that healthcare providers are trained. We are encouraged to move from patient care, thinking about really only the disease process that patients are experiencing, to really having a more holistic training set, looking at person care and considering an individual's life preferences, their support systems, and their well-being, and understanding that all of that is really intertwined with their overall health. And even beyond person care, we get to whole person care, which is where we also consider a person's context. So you can actually learn a lot about an individual when you have their address. You can understand their access to food and green spaces. You'll have an idea about whether they can easily afford your treatment recommendations. What kind of access do they have to healthcare and other community resources that will support better health outcomes? You really get a more complete profile when you think about whole person care. And this is why we're seeing EHRs, electronic health record systems, make the move toward becoming CHRs, or comprehensive health records. So Judy Faulkner, who is the CEO of Epic, has been talking about enhancing health records with contextual information, like the social determinants of health, things like living in food deserts or living in social isolation, among others. So I think all of this is very positive, and certainly there can be no doubt that where we live determines the pollutants we're exposed to, the community services that are available to us, how affordable and accessible healthcare is, and whether we're likely to suffer from preventable disparities. Now, while all of this other stuff is happening in healthcare, we're also seeing a shift or advancement, in my opinion, in the public health realm. We're seeing a move toward precision public health. Now, this is a term that was coined by Dr. Taryn Weeramanthri, the former Assistant Director General of Public and Aboriginal Health in Western Australia. Now, he's defined this term as the application and combination of new and existing technologies, which more precisely describe and analyze individuals and their environment over the life course to tailor preventive interventions for at-risk groups and improve the overall health of the population. Spatial technologies are a big part of this effort. So in my view, the world of the microscopic and the telescopic are truly parts of a whole. And I think what I've shown you so far is a recognition of that fact. And you might even say that the fields of public health and healthcare are experiencing a kind of convergence where they're more integrated, just like our technologies, to support both individual and population health needs. They kind of have each other's back, right? They help see each other's blind sides. And I firmly believe that geography is a part of the glue that brings precision medicine and precision public health together in useful ways. And as I move into a number of examples today that will demonstrate how GIS helps us to see health outcomes more clearly, I want to emphasize that a GIS is much more than a map. So if any of you are new to GIS, please hear me now. GIS is based on science, and in fact, we call it the science of where. And it's built conceptually on a kind of a framework and a process that's similar to our brains. We sense, we understand, and we respond. And we sense through measurements, geographic measurements. We see through visualization and mapping, and we model relationships and patterns. We make projections, interpret things holistically, and then we plan, design, and make better decisions so we can take action. Throughout the rest of this presentation, I want to touch on a number of examples of applied geography and GIS that support health in various ways. And I think you'll see the implications for precision in all of this. So let's start with a broad topic: infectious diseases and surveillance activities for chronic disease efforts, as well as an area that I call social diseases, which is really a commentary on our social structures that are causing major health and well-being concerns like homelessness. There are actually countless examples of how health organizations have been mapping and monitoring disease to give them a better handle on what their populations are experiencing. Infectious disease surveillance is perhaps the most common area of work. We see things from mapping malaria transmission in Kenya to the presence of African swine flu in South Korea. But many are also mapping chronic diseases like cancer and diabetes, obesity, smoking, drinking, and so much more. And then we get to even more truly contextual health problems. So understanding that impact of context on health is a prevalent area. It includes things like understanding the impacts of lead poisoning or low birth weight babies. And we also see more and more efforts focused on operational kinds of workflows, like monitoring wastewater for the presence of opioid medications or its metabolites, and monitoring patients in a hospital and that flow, as they're doing in Argentina. Now, vector-borne disease is a kind of natural application for geographic inquiry. And this map that you're seeing here resulted from work that I did with several colleagues and published in 2016 as Zika was outbreaking in the US. And we wanted to understand the preferred habitats of the Aedes mosquitoes, both on a seasonal basis, and those are the areas that you're seeing in yellow, and on a year-round basis, as shown in red. And we used the predictive analysis tool set to combine multiple habitat features like temperature ranges, precipitation values, elevation limits for the mosquito, land cover, and human populations, because we don't care if the mosquito is present if there aren't any people around. So what you end up with is essentially a risk map for Zika virus, and of course also chikungunya or dengue fever, all carried by Aedes mosquitoes. And you could use this information for mosquito control measures. And you could do really interesting things, like you could overlay the female population of childbearing age. So it would help you prioritize your vector control measures for early intervention to prevent microcephaly from Zika virus, as an example. Now, we put together a number of tools that many are using to do better work with the opioid epidemic. And in case you haven't been hearing about it, because all we seem to hear about is COVID-19, it's still a problem. And of course, you can map the drug poisoning deaths across the country. And you can see the areas in blue-green where opioid claims are higher than the national average. And you can dive deeper into prescribing habits, like in Clinch County, Georgia, where 10% of all prescriptions written were written for opioids just a few years ago. That was nearly twice the national average. And stuff like this gives you really clear targets for intervention to make a bigger impact. Now, Esri's efforts, our early efforts in particular, weren't focused on the quantitative data, actually. They began with this man, my colleague, Jeremiah Lindemann. He created this app. It's a crowdsourced story map representing real people and their stories in their geographies as a way to help convey the context and the relatability of those stories. Thousands of people have contributed to this map, and they're sharing the stories and the struggles of their loved ones who have been lost to the opioid epidemic and to overdose. Now, this map was created to build awareness and to reduce the stigma surrounding this problem. And here is the story, the first story on the map of J.T. Lindemann, the brother of the colleague that I showed you. And he was a really big sports fan, a loving father, maybe a slightly mischievous character. I think you might be able to see that glint in his eye indicating that. But he did lose his battle with addiction in 2007. And there are literally thousands of stories of really good people who lost their battle with opioid drugs. And maybe you hadn't thought of this way to use maps before, but it's been really powerful and impactful. In fact, the National Safety Council asked to take over this map so that they could promote it to continue to reduce stigma around this issue. But we did a lot of other things with GIS to support control of the opioid epidemic. These are more typical kinds of GIS apps. And we have apps, for example, that organize and share death and overdose data in a community. And we have pre-configured story maps that can help tell a unique story to a community that is impacted. There are apps that connect people with resources in their community, like pain control options that are not addictive, or chemical dependency treatment centers once somebody's already become addicted. Another resource meant to stem the supply of opioid medications is a locator for the drug drop-off locations. Now, this is a program that helps residents locate and the appropriate places to get rid of their unused or expired prescription medications so that they aren't a temptation or potentially stolen by a family member or a visitor to the home. At the same time, we have apps for law enforcement who collect and weigh the drugs that have been left in these drop boxes. And this helps them to get a handle on which drugs are circulating in the community and how effective each drop box is. Do people even know that they exist? Are they using them? Now, even Walgreens, who's an Esri customer, has created a national map with all of their safe disposal locations. Reducing that supply of prescription pain relievers by encouraging people to drop off their unused or expired drugs is a part of a national program that's collected more than 10 million pounds of medications, roughly equivalent to the weight of 22 Statues of Liberty. I'm sure you wondered why I had all those Statues of Liberty there. But think about this aspect. Does it not bring questions to mind about prescribing habits and why there's so much excess medication? Certainly something to examine. GIS can be used to track naloxone usage in the field. Quick mobile surveys can help understand when and where naloxone is used to reverse an overdose situation. Then we can look at things like the save rates to see how effective different people are. And when you view that information spatially, like on beats or territories, you can do several things. You can train officers and EMTs if you find that there are lower save rates in a particular area. And you can identify spatial patterns in the naloxone deployments so you can adjust your inventories to meet the critical needs. Because of course we don't need equal naloxone in every fire station or every police beat. We need fair, equitable distribution of naloxone. GIS can support citizen reporting of drug tips in a community. Like if you find a syringe in a park where your kids are playing, it's really easy using a mobile app on your smartphone. And those kinds of reports then can be immediately seen by the authorities who can manage follow-up investigations and interventions. And dashboards can enable decision makers with key metrics available at a glance. So now I hope that you can see this concept of a workflow for the opioid epidemic. I showed you data, visualized and analyzed, as well as apps that help in resource planning, community interventions, and outcome evaluation. Thinking in terms of workflows is very useful with GIS. To me, it's a way to enhance the value of your investment in this kind of technology by applying the tools to all aspects of the problem. Now, in a similar way, we can apply GIS to the homelessness challenge across our country. One of the ways that we begin is with homeless census counts. We get the numbers in the US through this annual count of people who are experiencing homelessness, and it's called the Homeless Point in Time Count. Now, this happens on a single night, usually in January, across the country, and thousands of volunteers are recruited and trained to interview homeless people to determine their status, find out how long they've been experiencing homelessness, and learn about their needs so that services can be planned. In this case, you see the traditional way that has always been done, with a clipboard and a pen. In the black hat, you're seeing Christina, who is showing you how a mobile phone can be used to quickly capture the very same information and add the location automatically. Interestingly, when we talked to people after doing this both ways, a lot of homeless individuals said that it was a little less threatening feeling to have somebody approach them with a cell phone versus the clipboard. So just an aside there. Now, this is a view of what the survey form actually looks like. Demographic information like age and gender and ethnicity are captured, as well as the length of homelessness during the current situation and how many times that person has been on the streets in the past. Now, once you've completed the count, you can start to look at and analyze the data, like this map, which is showing the relationship between two variables, which some of you who are using GIS will relate to. It can be difficult to do that with a thematic or choropleth type of map. What you're seeing is the total number of homeless people using a blue color ramp and the total percentage of homelessness across census tracts using the orange color ramp. Now, in the dark brown areas, you have both high numbers and high rates of homelessness. So maybe you're thinking, well, this is just an academic exercise to see both kinds of relaying of the numbers of the problem, but actually the two variables are quite different. Let me suggest why. In places where you have high numbers of homeless people, you would want to allocate funds to provide the needed services, right? You have to take care of the existing problem. But in places where you have high rates of homelessness, you'd really want to start looking for system level factors that may be causing increased homelessness in particular areas. Those are very different ways to allocate your resources. Now, when you have a place like Los Angeles County where you have both variables at play and lots of dark brown, then you're going to need to balance the way that you spend your resources accordingly. Now let's talk about resources from a different perspective. We're going to talk about it from a political perspective for just a moment. Resource allocation questions can get sticky. I'm sure that's not a surprise, and there are a number of scenarios that different administrations might value differently. So for example, this map is showing the places where resources should be placed to improve equity. And those are the areas in green. So in all of the scenarios I show you, focus on the green areas. So the idea here is if you place resources in those places, then everyone in the community is taking some of the responsibility for addressing the problem. Now, another alternative is to view this through the lens of access. An administration might choose to place resources in a geographic supply versus demand way so that those resources are nearest to the people who would use them. This map is actually showing where people are at risk for becoming homeless and placing resources in those areas so that maybe they can stay in their established communities, which is better for social support. And this is actually the strategy that's being used by the mayor of New York. And yet another method, which is used in San Francisco, California, is to centralize all resources, trying to gain economies of scale. And finally, this strategy is about using data on crimes against homeless people and high numbers of chronically homeless people as evidence of highly vulnerable populations of people experiencing homelessness. The idea is if you can focus in these places first, it would have the biggest impact on reducing costs, which would then free up budget for the other areas of homelessness. Now, there are a number of other options as well. Political options like locating new resources to prioritize access to transportation centers, or maybe giving preference to low crime areas. Or if you're considering a housing first solution, you would likely want to prioritize locations where permanent housing could be built or where existing housing could be converted into housing for the homeless. But since there are so many options, how do you choose one? How do you get everybody to agree, to come to consensus? Well, of course, GIS is great for that. You can overlay each of these different scenario maps and see if there are locations that optimize multiple objectives. So I'm showing an area that actually meets 4 of the different objectives that I went over. And this could be, again, a great way to bring together stakeholders with conflicting priorities so that they can work together when multiple objectives are being met. It encourages transparency and collaboration. There's really so much that can be done using a location perspective. Now, I want to speak for a moment about some COVID side effects and GIS. Now, maybe you're aware that childhood immunizations are decreasing during the pandemic. And actually, that's just one of several health issues that are worsening due to COVID-19. People are delaying their regular health needs like cancer screening, some chronic disease management, and they're suffering from the mental health burdens related to the pandemic. And those are sometimes leading to increased substance misuse and depression. It's really easy, of course, to see how this can happen when our attention is so focused in one direction. But the results, of course, can be dire. And so we need to encourage people to reconnect with their healthcare. One way that that can happen is through changes in healthcare delivery. So we're seeing a lot of healthcare organizations that are ramping up on their telehealth and their e-health options. And folks are using GIS to determine if there is sufficient need for those kinds of services. And they're doing that by assessing things like the travel burden across their populations. They're checking to see if the broadband coverage is adequate for these kinds of services, and they're refining the service offerings by understanding the underlying population health needs. Well, that telehealth example kind of leads me into this area of ensuring that people have access to care and services and using geospatial analytics to optimize our systems to improve that kind of access. And I wanted to use the example of stroke here because it's a very common health concern, especially among older adults. According to the CDC, stroke affects about almost 800,000 people per year, and over 140,000 victims die. Stroke accounts for 1 in 20 deaths in the United States. Those are pre-COVID numbers. And it's highly disabling and expensive as a healthcare concern goes. Now, access to care couldn't be more critical than for stroke. The American Stroke Association motto kind of says it all. Time lost is brain lost. The National Institute of Neurological Disorders and Stroke recommends that to prevent serious impairment or death for people who may be candidates for the thrombolytic or clot-destroying therapy, they should be getting from door to treatment within 1 hour. So I'm going to show you a series of maps that came from a Veterans Administration study of access. And even though these maps are older, you can see they don't look very modern. The study is really solid, and it's truly one of the clearest examples of spatial decision-making that I've seen. So I continue to share them because they're really good. Now, this first map highlights data for one of the 21 Veterans Integrated Service Networks. The black dots that you're seeing are the historical stroke patients over a 5-year period. Then you're seeing 2 primary stroke care centers. that exist within this particular region. And they're demarcated with the white H's, and around those centers, they calculated drive times in 15-minute increments up to 60 minutes, that critical door-to-treatment timeframe. What they found was that at baseline, their network served only 18.3% of stroke patients within that recommended door-to-treatment timeframe. So then they get to their planning scenarios. In this first planning scenario, they looked at assets that were internal to the VA system. Now, the VA has several what they call limited hours stroke facilities. So they selected one of those facilities to see how many more people could be served if they upgraded it to a full primary stroke care center. So it'd have to be 24 hours and have all of the treatments and bells and whistles available. Now you can see that with this scenario, it essentially doubles access for this particular VA region to 36.8%. In the next scenario, the assumption is that there may be funding to upgrade all of the limited hours stroke facilities. And when the researchers calculated access in this situation, they found that over 45% of the stroke population would now have best practice treatment available. But it's still not good enough, is it? In the third scenario, the VA is looking at a maximum capacity situation in which they not only upgrade their own facilities, but then they partner with non-VA stroke centers. Now this would enable ideal care for nearly 83% of their stroke patients. So the researchers concluded that being able to work through a number of different scenarios gave them an opportunity to jointly examine access along with their budget and their organizational politics and policies so that they could intelligently apply the resources they had to care for the greatest number of patients. Really smart. Well, this idea of geographic accessibility is also relating to the very current need to cite new resources during a surge. So I'll spend a minute talking about COVID. We've been seeing a lot of this for things like standing up new testing sites and distributing food resources in communities and extending healthcare services in places where hospital capacity actually becomes overwhelmed. So this uses a method called location allocation. And so let's say that we want to stand up new testing centers for COVID-19 tests. We begin by determining the demand, or if you're a health person, you're going to say need for this service. We can do that by overlaying all of the factors contributing to each of the 5 COVID risk types. And those are transmission risk, socioeconomic risk, susceptibility to the disease risk, exposure risk, and resource insufficiency risk. In the end, what you get is a risk ranking for all of these factors over small geographies that you may be interested in, like perhaps neighborhoods. And then to calculate the very best testing center locations, you would apply those risk rankings, and then you would pull in road network data so that you could calculate reasonable drive time and drive distances, because access is important. And then you input any other kinds of constraints you have into the model. Like maybe you only have a budget for 10 new testing sites, or maybe you have limited staff and you can only staff 5 new sites. No matter what all of these are, you can put them all into the model and it'll take those factors into consideration and select the most optimal sites from the entire population of options available. So you've put new testing sites into service, and now how do you help people find the resources that they're going to need? Well, this is where you again use resource locators like this one that actually comes from Valencia in Spain. And when you place a pin on the map, whether you're using a smartphone, a PC, or a tablet, the user is able to get information about the nearest hospital or pharmacy, social services, or testing site in the area. And I think there's no question that certainly COVID-19 inspired a lot of great innovation. And in all of these kinds of applications, we're really connecting the dots to support response to the pandemic and other kinds of health issues. In this particular case, we can actually go a step further. We saw GIS used in the large-scale COVID-19 testing that was done recently in Slovakia. Now, they aimed to test the entire adult population over 2 weekends in October, and GIS provided residents with up-to-date wait time information. And that data, displayed for them on dashboards through a cell phone app, helped them to self-distribute among the different testing sites, and it regulated overall occupancy at each site. So it was really a win-win for everyone. Providing access to care and optimizing systems is incredibly important to build strong and equitable systems. But how do we decide what kinds of systems we need to optimize? I would say that probably the area of health GIS that most requires strong analytics is the assessment of community level outcomes, relationships and gaps, or disparities. Around the world, there's a lot of effort to use mapping to better understand racial and ethnic disparities or notable vulnerabilities, like they're doing in Finland. In Lebanon, actually, they're using mobile survey tools to better understand the lived experience in disadvantaged neighborhoods. And across Europe, they're putting together efforts to analyze civil unrest and identify and manage those pockets of unrest, especially in the areas of high COVID case counts. GIS can make the complex more simple. Like, take a look at that risk map that I put up for homelessness. If you can understand that certain areas of a community experience more homelessness because of unemployment, while other areas in the community are experiencing or generating homelessness because of domestic violence, then you can start to put the right intervention in the right place to start to solve the problem. So how do you find those disparities to analyze and to understand better? Well, you would do things like community health assessments. And actually, I'm really pleased to tell you that just last week, we released a new set of tools for performing community health assessments. And these tools follow the World Health Organization's CASPR methodology for selecting a study area and random household clusters based on census statistics. Once you've selected your neighborhoods to be surveyed, you'll need to assign teams to their clusters. And you can easily make those assignments. You can provide useful comments to send the information along with a digital map of the area that has been assigned to each team member. So it's all automated, makes it really easy. Well, then we get to the real work, right? We used the US CDC's Bank of Community Health Assessment questions to populate our digital survey tool. And we also added some COVID-19 questions. And the survey is actually really easy to customize and add new questions or modify the existing questions or even hide the ones that you don't want to use. Now on the right, what you're seeing is a dashboard that monitors the submission of surveys in real time. So we can see how well the teams are doing in terms of their efficiency. We can look at whether householders are being cooperative with the assessment and the overall progress toward completion of all required surveys. So take note for a second that I've showed you already a few different places where a mobile data collection tool is combined with a dashboard. It turns out in health, this is a really powerful combination and is used for a lot of different purposes. Well, finally, you get to the good stuff in your community health assessment. A pre-configured dashboard with overall characteristics of the surveyed population is available here for you. And the dashboards are certainly configurable if you have different needs for your community health assessment. But in this one, we included things like population breakdowns by race, ethnicity, language, pregnancy status, age cohorts, and some financial characteristics that could impact health. Okay, so I've shown you how GIS can be used to monitor disease, consider access to care, and assess community needs. So how can geography be used to improve clinical outcomes? Well, let me start with a very common problem that hospitals face, the readmissions problem. This is where a patient returns to the hospital within 30 days of their discharge, for the exact same problem. It turns out this is a very expensive and often preventable problem. Initially, it was expensive solely for CMS and other insurance providers. However, nowadays, hospitals are being penalized by not, in a way that leads them to not get their reimbursement for their excessive readmission rates, if that's a problem. So now everybody can be somewhat unhappy about this problem. So there is a lot of motivation to continually find ways to solve the problem. And actually years ago, Dr. Atul Gawande wrote an article called The Hotspotters for the New Yorker magazine, and maybe many of you have seen this. In it, he described the work of the Camden Coalition in New Jersey and their efforts to bend the healthcare cost curve by focusing on the readmissions problem. And so their approach was pretty unique. Rather than analyzing readmissions by the traditional way, which was to look at different disease types, they tried something totally new. They looked at their most complex patients regardless of the disease type, and then they grouped them. Then they performed a geographic hotspot analysis on the complex group. And they found that many of their super utilizers lived in just a few of the area's low-income housing complexes. And then they set up small primary care practices right in those buildings. And that improved access to primary and preventive care doctors to manage chronic disease conditions and also help with more acute problems like head colds and earaches that saved unnecessary visits to the emergency room. And here is the astonishing return on investment that they achieved. First, they clearly improved the quality of care while also reducing readmissions costs by an average of more than 50%. In today's world with COVID-19, we need to preserve our ability to provide clinical care to everyone who needs it. This is why people are using analytic methods to perform capacity forecasting. And this is where models can pull in hospital utilization, hospital bed utilization data and pair it with social distancing behavior information and start to predict what might happen over time with local hospital bed capacity or even ICU bed capacity or ventilator capacity. Obviously, every hospital and every government wants to be able to predict whether their curve is going to stay flat, which would maintain the health system's infrastructure and their ability to care for each person who walks through their doors, or if some hospitals might become overwhelmed and exceed their capacity to provide care, something that I think many of us are worried about following the Thanksgiving holiday. So while geographic analysis can help with superutilizers and readmissions and forecasting the overall capacity of our system, it can also be leveraged to empower patients by connecting them to relevant resources. Now, what you're seeing here is a screenshot of the wellness map. This was created by Loma Linda University Health, and it's integrated with their Epic electronic health record system. Through the patient portal, which is called MyChart, a patient is able to use the wellness map to do several things. They can interrogate the locations in the blue section, which relate to their own personal health care. It has their appointments and locations, their referrals, nearby labs and pharmacies, as well as urgent care centers, right at their fingertips. In the green section, patients can locate nearby wellness resources like open spaces for exercise and healthy food options. But my favorite part is the orange section. This is where the patient will see community resources that are relevant to their individual health concerns. For example, if a patient has diabetes, they only see resources relevant to diabetes on the map. It seems to me that this truly exemplifies what I was talking about before with precision medicine and precision public health coming together. Now, in this last example that I'm going to share with you today, I want to introduce you to Pat Dolan, a friend and a former Esri employee who joined a new community, a community of ALS patients a few years ago. He has given his permission for me to share his story. And Pat has been a longtime technology guru when it comes to applied geography. So it really wasn't too long after his diagnosis that he began to apply his 25 years of experience to his own disease. He realized that from a patient perspective, he really wanted to know about how to get care, how to increase his chances for a cure, and how to get support for this new reality in his life. Pat would tell you that from a patient perspective, location is everything for the chronically ill. He can simply put a pin on the map for where he is, and this is actually Esri headquarters to preserve his location privacy. Now, if you are able to see in the upper right panel, this app is set to find resources within 30 miles of that point. And so a list of results is returned from this app that Pat built. There are 3 clinics within 30 miles that specialize in ALS. Loma Linda is the nearest one for Pat. Actually, he didn't know this, and he was driving all the way to Los Angeles, an hour and a half for every appointment. So the app did really help him. If he clicks on this, he can get more information about Loma Linda, and he can even use the app to navigate there if he wants to use it that way. The app also has clinical trials included. He pulled in data from clinicaltrials.gov on ALS trials, and he set up the app so that it is only showing trials that are currently recruiting new patients. And similarly, he is able to explore the local support groups for his disease. But Pat wasn't nearly done yet. Through all of his research, he happened upon an article as he was searching PubMed entitled "Using GIS for Spatial Analysis of Rectal Lesions in the Human Body," and this gave him an idea. He used the information in that article to inspire his work in occupational therapy. And I know you thought I was going somewhere else with that, but anyway, Pat's left hand was the part that was especially impacted by his disease. And so you can see him in this picture. He works regularly with Joyce in occupational therapy. And to track his progress with his hand grip, Joyce measures Pat's hand at every visit and the various degrees to which he can flex and extend his fingers. And she logs that data in a spreadsheet. But as you can see, it's really impossible to visualize that information in any meaningful way. So Pat got to thinking about how he could use 3D geographic modeling to do better, like they did in the colon example. So he used this design application, which was created to represent geographic information in 3 dimensions. So here you can see, of course, the lovely city skyline. And then we can zoom in and see the location of a proposed new train station. And we can view it from all sorts of different angles, maybe looking at the various station platforms. And with this app, we can also look at alternative designs. Now, maybe this is starting to look a little familiar. It is, of course, a hand. And in fact, it's Pat's left hand. So he took the measurements from Joyce's spreadsheet and he applied them as rules in the application that's shown for you on the right. And this set of measurements that you're seeing now are from the beginning of Pat's therapy, which was in July of 2017. And then you can see August. And at the end of September, you can see real improvement in his ability to grip. Pat said that the difference had been enough so that he can now pull up his own pants, which is not only an important improvement in his independence, but an imperative preservation of a person's dignity. So this ability to visualize his progress, which he didn't realize he was making, helped him to stay motivated and keep going so that he could get there. It served as a potent reminder of his progress, and it pushed him to continue his therapy despite all of the challenges that he was facing. So I know I've covered a lot of ground today. When it comes to the big picture, I hope that you'll remember this. Applied geography helps us consider a person's context, that 80% of the factors that impact their health outcomes. By taking that telescopic view, we can better achieve whole person care, precision medicine, precision public health, and a very human approach to individual and population health. And I do want to thank you for your attention and really the privilege of being with you today. I wish you all certainly good health, and I'd be happy to take any questions.
Este, thanks so much for that tremendous keynote address. I've been in this field for a while. I am too embarrassed to admit how long, but I remain insightful about a lot of the applications and the motivations that you spoke about. And it was a learning process for me for sure. And I'm sure everybody in the audience appreciated it just as much. So thank you for that tremendous keynote address. I will send it over to Tim now to do some Q&A.
Yeah, hi, Dr. Geraghty. Thanks so much. That was an awesome talk there, and you really covered a lot of ground. I want to go straight to the question and answer box, and we'll start there anyway. Actually, there's a very specific question early on. I think it was around slide 19, where someone's asking what type of data display was used in the long-term trends map. This is you had.
Yes, I know which one.
Trends by county. Yeah.
Yep. Yes. So you can Google this. Look up COVID pulse as one word, COVID pulse, and put Esri next to it, and you'll get to the right place. It's on our Living Atlas site. And those little lines are called spark lines. And they are a graphic technique that is meant to convey a lot of information at a glance. So there's no axis, there's no words, there's no numbers, and they're meant to be comparable from place to place, at least in this map. So the spark lines in this case are showing the beginning of the pandemic to the current day, and that trend for each state, and then you can dive in deeper and see each county in the state. And actually, we put out a blog yesterday. We upgraded the map so that you can look at it in a totally different way in grid view. So I encourage people to take a look and try it out. There's lots of great stuff in COVID Pulse.
Excellent. Okay. There's a couple questions that came in when you were talking about the homelessness point in time app. One of the questions is with, let me read it out here. You're talking about how you're sharing the data, and there's a question or a comment like, is it more effective to share the drug data with law enforcement rather than the public health officials and community advocates? So it's really, it's more about like a dissemination of data question or findings question.
Yeah, so I guess I wouldn't want to answer if one is more or less effective than the other. I think my answer, especially when you look at problems like opioids or homelessness, these are very systemic problems, and they have multiple stakeholders, not only public health, public safety, healthcare as a stakeholder. In the opioid epidemic, you might have the education system as a stakeholder, the pharmaceutical community as a stakeholder. So I think finding ways to safely share information with all of those stakeholders so that you're working from the same authoritative data, much like the JHU data, to be honest, you can see how amazing things can happen when everybody's involved. So I would probably avoid saying one or the other is more important. I think what's important is inspiring methods and policies around collaboration.
Excellent. Also, in that same, when you were on that section, another question came in, and it's really kind of indicative of a larger question here, but the specific question is, have you probed the marginalized participants about their comfort with location and substance use being recorded? And I think this is kind of a larger question that we all kind of wrestle with is, well, we're collecting all this great data, spatial data, location data, there's privacy issues. And how does Esri, keep that in mind as they're developing all these great tools to, collect and use and analyze this data?
Yeah, so I'll take that as a two-part. So when we're talking about the opioid epidemic in particular, the only place where we're really collecting field data that is individually based is during an overdose, and that is the police or the EMTs responding to the overdose can collect that data. and then bring it back to analyze it themselves. So so I don't think so. The person has already overdosed, non-communicative. There is no Q&A there about their permission or their feelings about it. And of course, the privacy laws are different in emergencies, and that's worth knowing about. And of course, in this case, we cross the boundary between HIPAA and CGIS laws and all of these things. And then there's the emergency component. So we have not asked those questions. With the crowdsourced story map I showed you, that's completely voluntary, and it's done by the families and friends of people who have passed from opioid overdose. But you are right that the bigger question is about privacy and sensitivity to any kind of protected information, whether health or other identifiable information. And at Esri, we're very concerned about being responsible and a trusted technology tool for people to use in their analysis. So the way that we've approached this, one is certainly I would recommend that if you are geocoding protected health information or analyzing protected health information, you need to be secure on your own enterprise system or your own desktop system that's password protected and meets all of those kinds of requirements. But I will tell you, by the end of the year, you'll be able to use your desktop and geocode protected health information in ArcGIS Online. You can't yet store your protected data on ArcGIS Online, but you can geocode it by the end of the year. Give us one more year and you'll be able to store it with a measure of safety. You can also read the trust.arcgis.com site to get really specific about different tools, our mobile tools, our enterprise tools, desktop tools, and ArcGIS Online. Now, the other part of it is you do want to share your data at some point. You want to share visualizations, or you need to share with somebody else, and there are a number of methods to do that. So we have a business partner. They're called GIS Inc., and they built a product that we really encouraged and we think is fantastic, called MapMask. So it's MAPMASQ as one word. And they have a website and it shows demos there. MapMask is a tool that acts like an extension to ArcGIS Pro. And so you pull it in and you can do geomasking and get statistics like k-anonymity to make sure that it meets your own governance structure of what is de-identified data. Or you can do different kinds of aggregation or anonymization, like modifying your lat longs with a random number at the end or truncating it. The reason to work with lat longs, for those of you who are GIS geeks, is it keeps all of your attribute data, right? If you aggregate, you lose all of that individual attribute data, but if you truncate or somehow obfuscate your lat longs, then it really just stacks them up and you have all of your attributes. It starts to look like a grid. There's also tessellation grids that you can use for de-identification, whether you want to use a fishnet or hexagons or triangles. They obscure some of those boundaries that people are familiar with and might increase identifiable information. So we take it very seriously. I have a webinar out there. If you Google navigating HIPAA in a geospatial world, you will see all of these things in action and my take on how we work with the privacy and security laws within HIPAA.
Excellent. I think the next couple questions kind of get lumped together too in a way. You know, part of it is a general kind of question about where do you see or Esri's development going in the future, you know, in terms of health related data and GIS. And then there's more specific, a lower tiered question about the dashboards. I mean, you know, the COVID dashboard certainly has turned on the whole world to, you know, the power of spatial data. It's been great. And you know, kudos to Esri for enabling this platform to produce this kind of data. Are there more plans for that dashboard? I mean, there's capabilities that are available now, but are they going to increase them to maybe increase more spatial statistics or that kind of stuff in the dashboard itself?
Okay, so for the first part of where are we going, I would say that the first one I've already mentioned is tightening security so that you can work in ArcGIS Online. And the reason for that, of course, is we know that many health organizations as well as individuals, want to be able to work in the cloud and not carry all the infrastructure and use services. And so we want to be able to support that even when you have sensitive data. So look for that coming by the end of 2021. We're also working on things that are going to enhance what I'll say is data interoperability. So as a platform, the ArcGIS system has a lot of interoperable tools, and many of you have already used those. But we have sort of gone with the notion that because there are geographies in common, that is a great method for data interoperability. Well, you're going to see coming in the future, we're going to take that a step further, and you're going to see some exciting things happen with data interoperability. With dashboards, I think you probably will see some more statistics. There's kind of this, it's not exactly an overlap, but it's maybe a perceived overlap of our ArcGIS insights and ArcGIS dashboards. And there's some functionality and insights with the different cards being very interoperable and being able to do some quick analytics that people are wanting in dashboards. And so while I don't know the roadmap to address this question, I know that we've already made progress along those lines, and I suspect that will continue because we've probably never been more incentivized to make dashboards the ultimate tool than we have been this year. So.
Exactly. Yeah, they're the thing now. Yeah. Okay. Another question here is talking about data gathering and analysis. There are definitely challenges to make these intelligent. Has there been an assessment of how different states are with respect to GIS and policymaking? Which states are doing well? Which ones need more capacity building? And for the rest of the world, is there data about like authoritarian governments and GIS deployment?
So it's an interesting question. I would say probably my response would be that, we have more of our anecdotal opinions. There are certainly different kinds of assessments. Like I think of for hospitals, there's Most Wired, and I do believe there are those kinds of assessments for government organizations. I don't know if they go specifically to the health departments. When we look at those kinds of assessments, we did do a project this year, which was sort of interesting and along those lines, where we partnered with the CDC to standardize and automate state dashboards for any state that wanted to take advantage of this. It was paid for by CDC, so it was free to every state for COVID-19. So wanted to be able to present, 2-week trends and case data and death data at a certain level and some disaggregation of information across the dashboard. So that was a nice effort at some standardization so that it could be federated at a national level. One thing that I think is maybe also related, but I don't feel like I'm seeing it enforced or played out enough yet, was 2 years ago, I think it was early 2018, the federal government passed 3 laws, and they were about data sharing and geospatial data. And there was a requirement that any data that could be geocoded should be geocoded. But I don't see everybody, following these advisements. So maybe there hasn't been enough outreach about what's actually out there, but that is the direction that everybody needs to go. I tend to think that in some places we're a fair bit away, but I also think a lot of people stepped up their game this year to make the future a little brighter.
Excellent. Here's a question. I know that the person who asked the question, she's in-house here at the School of Public Health, but she asked, do you have any suggestions on how to share announcements or solicit participation for research studies that include invitations for crowdsourcing survey data? Here at the School of Public Health, we're always trying to get our hands on data, and there's a way Esri helps put out helps augment or springboard for these types of crowdsourcing to be initiated.
Yeah, so I'll mention one way that we've been doing things and one way that gets even more scientific. So the first way that we've been doing a lot of things lately is using the experience builder to build so we've been doing some roundtables. Of course, we're all doing a lot of virtual meetings, and we don't want them to all be webinars, right? We want to have some back and forth. And so we're doing some roundtables. We're using Survey 123 to have people register, and it's on this Experience Builder website. And we're connecting it to automatic emails that send out the Zoom link invitation, and then providing that either a story map or just information on what this roundtable is about. But the fact that you can sort of do it on a mobile phone with a Survey 123 app has, I don't know why, but it seems like it's increasing participation. You would think it would be the same as a landing page, but I think because it's so fast to stand up, maybe you get that benefit of time. But the scientific method that I will mention is using some of our consumer behavior information. So if you have the Living Atlas for some things, or our business analyst or community analyst products for others, we have all sorts of information in there about language spoken in different areas of a community, preferences for how people get news, whether that's on a smartphone or cable TV, or they still subscribe to a daily newspaper. You can look at people's social media preferences. In some places, it might be Facebook is #1, and in other places, maybe it's Instagram. Using that information, if you are looking to get the broadest participation, you might want to target different channels based on the community you're trying to get to attend. And of course, it never hurts to advertise all of this stuff broadly and frequently on social media, but we all know that.
Excellent, thanks. Here's another question about, this came up during the predictive analysis section, and you're talking about modeling Zika and the habitat for the Aedes mosquito. It comes to, to the forefront that, geographers, we can put all these tools together to, integrate all these layers to make sense of them and analyze them, but you kind of need some expert opinion, right? You need some kind of entomologist to tell you what's important to the Aedes aegypti mosquito. So how does Esri bring these varied specialists into the tent to get their inputs for these types of tools?
Sure. Well, in this case, it was a study that was initiated by one of my colleagues who is a medical geographer and was attending George Washington University, I believe. And so he was a part of a group of experts. I will say, in terms of Aedes mosquito habitats, there's actually quite a lot of literature, and we did a review to understand what multiple researchers said about the habitats. What's nice about this particular type of study is, there is a temperature range, and people say this is the temperature range, and you may see some slightly different variances, but they're not a big deal. It's not like a soft metric. It's a very hard metric. So that makes it very easy. But to the bigger question of how do we partner, we are really strongly encouraging of the GIS related research work at universities, and we can partner in a number of ways. We have a ton of subject matter expertise across the board at Esri that could be asked to participate in research, recognizing that we're a business, so we can't be a full-time researcher, but we can provide expertise and input as a contributor, and we do that. And then we also sometimes provide letters of support if our software needs to be used, or maybe some consulting services are provided, or maybe we provide some training materials if you're doing some community project. So you can always come to Esri and ask for a letter of support if we can help you get your research done. And then we also love to promote the good stories. So don't forget, even if it's something in a very academic journal, we can make it general public ready so that we can share your good ideas with the whole world. We love to do that because we're basically storytellers at heart. So that's how you can work with Esri, a number of different options.
Great. Here's the last question from the QA box. Thank you for the massive amount of information you provided. I noticed that most of the analysis and visualization was spatial and spatial granularity at the county level. I wonder if the temporal aspects with the different time granularity was being considered. Health is sometimes something that it varies so much over time, as well as spatially.
Yeah,
I'll
that's
let
a
you
great
respond to that.
Well, one of the things, there was something that I didn't include because I said a few things about COVID, but I didn't want to focus there. But we saw a lot of great temporal analyses related to social distancing data and how that changes over time, and it changes with the weather, right? It gets warmer, people go out, they go to the beaches, regardless of whether there's a pandemic. So we certainly consider the temporal component. I would say of the things I showed you, probably the most relevant to that question might have been the community health assessments, because one of the points of doing those is to look at change over time. You assess your community and point A, maybe pre-pandemic and then post-pandemic. What are the changing needs of the community and how can public health respond? So absolutely, the temporal component is important. And I appreciate the note because I should include more of that. And if this is something that you're particularly interested in, I would encourage you to look up a brand new tool that was put out in July around the user conference of time series forecasting. It's a pretty cool tool because it will fit your data to multiple different types of time series forecasts, so that you don't have to be too much of an expert in time series forecasting to actually use it and get some good results. So definitely, I apologize for not adding more temporal stuff. We do appreciate that component.
Oh yeah, well, there's only so much time we have, but I'll hand it back over to Frank. But thank you for addressing all those great questions there.
Yeah, they were excellent questions. So thank you for the attendees for posting those questions, and of course thank you very much to our keynote speaker, Dr. Este Geraghty, for providing us this tremendous keynote address. Just to remind you before we close out, at 3 o'clock we have a set of lightning talks. I think we have about 10 of them. These are from students and other affiliated members from the school and on a variety of topics. And then 2 sessions tomorrow. One at 12 o'clock on the role of GIS during the COVID-19 pandemic, and this one is going to involve the developers of the well-known JHU COVID dashboard. And then we'll end tomorrow at 3 o'clock with mapping industrial food animal production. So I want to thank everybody again for coming. And I want to thank our sponsors, the Center for a Livable Future and the Spatial Science for Public Health Center. We have dropped links to those centers in the chat box, as well as links to the registration, where you can see this presentation and also register for tomorrow's sessions and also this afternoon's session as well. Thanks again to everybody for coming. Special thanks to Dr. Geraghty for her tremendous keynote address. Enjoy the rest of the day, everybody, and we'll see you again at 3 o'clock.